Hello, this is Dr. Mark Proctor here to review the molecular genetics and principles of craniosynostosis. The objectives of this presentation are to outline the different types of both syndromic and non-syndromic synostoses, to summarize the major genetic mechanisms behind their pathogenesis, and to present a genetic testing algorithm that can be of use in your clinical practice. Introduction. Craniosynostosis results from a perturbed maintenance of suture patency during cranial development, and this produces a recognizable pattern of skull-shaped malformations. The malformation type depends on which suture or sutures are affected. The incidence of synostosis is approximately 1 in every 2,000 to 2,500 live births. It can occur either as an isolated non-syndromic phenotype or may be part of a syndrome, some of which are quite complex. In general, we estimate that approximately 85% of patients have craniosynostosis that is sporadic and what we would consider non-syndromic, and the remaining 15% have a syndromic variant. Syndromic craniosynostosis has generally fallen into a pattern of well-described clinical situations. So when we look at things such as Apert, Cruzon, and Pfeiffer, these were described based on the phenotypic characteristics before the era of molecular testing. Now that we're in a new era of testing mutations in genes that encode for many of the FGR receptors as well as transcription factor twist1 have been found in patients with Cruzon, Apert, Pfeiffer, Muncke, and Séthré-Jotson syndromes, among others. The majority of these syndromes have autosomal dominance inheritance, although the clinical presentation can be variable due to incomplete penetrance of the disease. Looking at the various syndromes, one of the more recent ones is Muncke syndrome. This was first described in 1994, and it's caused by a mutation in the FGFR3 gene. It has a much more varied phenotypic presentation, and it is believed that many patients who previously were thought to have non-syndromic unilateral coronal synostosis may in fact have had Muncke syndrome. Apert syndrome is a very well-known and understood syndrome, and part of this is because it has very classic findings in addition to the synostosis of syndactyly of the fingers and toes, in addition to substantial midface protrusion. It is caused by a mutation in the FGFR2 gene, and many of the cases are spontaneous mutations, often occurring de novo, and are often related to advanced paternal age. This is consistent with many diseases seen in synostosis and neurosurgery, such as Pfeiffer, Cruzon, and Apert, in addition to achondroplasia, which are considered part of the RAMP spectrum, RAMP standing for recurrent, autosomal dominant, male biased, and paternal age related. Pfeiffer syndrome is another syndrome that has been well described over time. Some of the most severe cases of synostosis are Pfeiffer, and that would be the clinical subtype 2. So when we think of cloverleaf skull, that's generally syndromically thought as Pfeiffer type 2. And these are FGFR2 gene mutations. Cruzon syndrome is another one that has a very similar but varied phenotype. So almost all of these children will have midface hypoplasia in addition to synostosis. It's often affecting the bilateral coronal sutures, but can also commonly affect the sagittal suture. And the FGFR2 gene is the one that's generally the culprit. There's a distinct subtype called Cruzon syndrome with acanthosis nigricans, which has associated dermatomal skin changes. Sethrae-Chosin is another one that was discovered a fair while ago, now getting on 100 years. It has a overlap with many of the other syndromes, and Muncke and Sethrae-Chosin can be difficult to distinguish, but some of the defining features of Sethrae-Chosin include ptosis, as well as broad thumbs. The synostosis will often be unilateral, but can be bilateral coronal. Jackson-Weiss is another syndrome principally described from one large family, and the mutations in this case are on another domain of the FGFR receptor. If we think about non-syndromic synostosis, the reality is we now think of synostosis in a very different way. We used to think of syndromic synostosis as those phenotypic conditions that had both synostosis in addition to other features such as the syndactyly in Apert. And we thought of non-syndromic synostosis as essentially single suture synostosis. In this day and age, we are much better at now describing the genetic basis of disease. So we don't think of it so much phenotypically as we do genotypically. As we think of non-syndromic synostosis, sagittal synostosis is clearly the most common and can affect up to 50% of individuals with synostosis. This results in the typical scaphocephaly and unilateral coronal synostosis, which results in anterior plagiocephaly. Metopic synostosis is also seeming to have an increased prevalence these days. When we think of non-syndromic synostosis, we do know that the incidence for children of affected members having the disease goes up to about 5% from 1 in 2,000. So even when we can't find the gene, we believe there's a likely genetic origin. ERF is one of the very recent genes that's been discovered that seems to be a big player in non-syndromic types of synostosis, as previously described. EFR was first discovered in 2013. There's an overall prevalence in all synostosis of about 2%, and for non-syndromic synostosis, this appears to be in the range of just under 1%. Many cases these days of sagittal and lambdoid synostosis seem to be EFR related, so we're finally making some inroads into single suture synostosis. This slide is a very useful algorithm for how to evaluate a patient who may be coming into your office. If it's syndromic synostosis, there's now what's called a cranio panel, where they send off a typical set of genetic testing that can often lead to the diagnosis. If this typical pattern is not seen on the cranio panel, then microarray can be performed as well. As we look at the non-syndromic, or traditionally thought of as non-genetic types of synostosis, we now know that many of these are genetic. As you can see on this slide, for children with coronal synostosis, there's an array of tests that could be sent, looking in large part towards Sethrae-Chosin and Muncke syndrome. For sagittal or metopic, especially if it's familial, you can test for the ERF, as we had outlined, in addition to SMAD6, TWIST1, MSX2, and occasionally others. For lambdoid, there's really been no clear type of genetic association identified outside of the ERF gene, and for these you'd have to go to whole genome exome sequencing. So in conclusion, looking at the molecular genetics of cranial synostosis is really a burgeoning field, and our understanding is constantly in flux. What we used to think of as non-syndromic synostosis, in this day and age we really think of as isolated synostosis, but most of us believe that even in these cases there's going to be a genetic origin, a generic basis of disease. As such, the phenotypic expression of cranial synostosis is playing a lesser role, and the genotypic characterization is playing a greater role. The genetic testing algorithm for syndromic and non-syndromic craniosynostosis, as outlined on the prior slide, will hopefully offer some help in how to look at the patients that come into your office. Thank you very much.